Thank you. My name is Judy Friesen, and welcome to the report out for RPIW number 55. Our RPIW is in regards to COPD referrals to the home care nurse practitioner. And this is our standard work combination sheet. There was 5 members on the team, and we're reporting to a tack time of 20 minutes. We named ourselves the Breathless Cuties, and I'd like to introduce Nell, our patient family advisor. Amanda's on the team as a pharmacist. Tanya is the nurse practitioner in home care, and Terry and myself are the co-leads on the team. And I'd like to thank Wanda for her great support from Quality Improvement. Thank you. So our theme is COPD clients in the community are better able to manage their symptoms and have more timely access to care with the support of the home care COPD program. This RPIW is directly linked to the strategic priorities of the Pia Parkland Health Region in regards to ED wait times by reducing the wait times by 60%, with a regional target of decreasing hospital utilization of COPD clients by 10% by March of 2017. So we were pleased to be able to tackle this issue. Our project form has a lot of detail on it. I'll just briefly highlight our improvement title. And it was to improve the process to identify COPD clients who require additional support, link them with the home care NP, with the intent to minimize emergency department visits. This is our target progress report, and key measures we looked at were the walking and travel time in the current state, the lead time or the amount of time to find clients, and at that our lead time was 27 minutes and 18 seconds for find one client. Quality measures were around awareness of the emergency department physicians and family physicians of the COPD program. This is our current value stream map, and as I said, we had a lead time of 27 minutes and 18 seconds. We identified Kaizen bursts or areas for improvement, which included the NP currently collects the data daily in person, going from the home care department to the emergency department to collect the data. There was few referrals being made from physician clinics. There was gaps in identification identification process. If the NP isn't at work, then it didn't get collected. And there was lack of knowledge about the NP COPD program by both the emergency physicians and the family physicians. We calculated our TAC time based on 2 referrals per week to the home care NP. And we ended up with a TAC time of 17.5 hours. So this would mean that one client would have to leave the system every 17.5 hours to keep it in flow. The nurse practitioner is keeping stats in regards to referral sources. And this graph is a 6-month collection of stats. The green is the referrals from home care. Blue is the referrals that the NP collected. And then there's also hospital referrals and emergency department referrals, which are limited on the graph. So you can see most of the referrals came through home care. This is our time obs form, and we monitored the NP leaving the home care office, going to the emergency department, looking at the pink registration forms and identifying COPD clients, and then returning back to the office with a cycle time of 27 minutes and 18 seconds. This standard work combination sheet is just another depiction of the time ops form. And we have the spaghetti diagram, which shows the steps, a total of 332 feet from the parking lot to ED, collecting information and returning. So this is the current state. You'll hear from the rest of the team that this process has been eliminated and replaced with alternative processes.
My name's Amanda, and I'm a pharmacist here at the hospital. During this RPIW, we discovered there was no clear referral process for referring patients to the nurse practitioner. So currently, the nurse practitioner would travel from her office at home care to the ER to each day to find COPD patients who were admitted to ER over the past 24 hours. So this was very time-consuming and inefficient. So this is a chart, data taken from September 15th to October 15th. So there were 30 COPD clients accessing Emerge during that time. 15 were admitted and 15 were discharged. So of the 15 discharged, 3 were identified by the nurse practitioner through looking through their date sheets. So after much digging and discussion with ACAP, nurses, and ER physicians, including Dr. Kurtzy, as a content expert on this RPIW, it was determined that there, number one, was no referral form, and number two, that they would like a referral form. So something easy and quick to use. So all they need is to put a Windows label and check mark which program they'd like their patient to be referred to. So the referral form is great because the nurse practitioner no longer needs to travel to ER. And hopefully this will increase referrals to the nurse practitioner and decrease ER utilization. So we displayed this referral form in the emergency department, and we also left a nice big staffing Emerge for the physicians to use. We've also created a multi-skills training schedule. So GNP will ensure that each physician is fully aware of her scope of practice and as well as how to use the new referral form. And just to further clarify, this form is actually just intended for ER at this point. There's a concurrent program in the works for inpatients called the COPD Care Program. So in the future, we hope to collaborate with that team to hopefully further target all COPD patients, inpatients, and outpatients.
Good afternoon. My name is Nell Heckel. I'm a patient family rep and have been retired for some time. My nurse practitioner suggested that I get involved in the RPIWs as I do enjoy meeting new people and working with them. And it's really good to see so many familiar faces. The home care COPD program seemed to be a secret, and Tanya, the nurse practitioner, was so excited to establish it. So what better way to get started putting it together, putting this brochure together in plain English. The brochure describes the role of the nurse practitioner and the services she can provide. Wanda and I visited the Fit Life Center and spoke with 10 people with COPD. We found that no one was receiving home care and no one had heard about the nurse practitioner. These people were quite independent and felt that they didn't need any additional support at this time. But we all know that there are many people who are not one bit interested because of depression or too stubborn to join this program to get help, as my sister was. I lost my sister 3 months ago from COPD, and I wished I'd known about this program then. It was great to see so many people being active and enjoying life more fully. Also, since there are many lonely people living alone, they do enjoy getting a phone call or have a visit with someone. As we assembled the brochure, we certainly did many revisions. So thanks to everyone's input to make it possible to complete this brochure. We distributed these brochures throughout the hospital, and the plan is to distribute them to the doctor's offices. We hope that if people with COPD get involved in this program, there will be a reduction in ER visits.
Hi everyone. My name is Tanya Miller, and I am the nurse practitioner that works at home care. So one of the problems that we found while we were doing this RPIW and we were digging all the information up was that the family physicians didn't know about me at all, and they didn't know what I could do, and they didn't know about the COPD program. So that meant that no referrals were coming in from that source, and this created a lot of confusion among the family physicians because they didn't really know what I was supposed to be doing. And as we were doing this, we really saw a need to catch all of those patients, because if we caught them before they went to the emergency department, then we could reduce those visits. We were really thinking a bit more upstream. So we wanted to distribute a memo to the family physicians that would introduce myself, my role, and the expectations of the communication piece that would go back to them. And really just a brief description of how I could supplement or enhance their services. And we also wanted to make a change to our home care referral form, because we were told, no new forms, because that's just confusing. And we also wanted to develop a program brochure to let the people know about my services. So before, the status before we started was that there was possibly a memo that went out to some of the family doctors, but they were we couldn't really find any evidence that it had ever been really circulated. So there was no referral form specifically for me in the emergency department. There was no specific box on the home care referral form that was for me. And MP services were not even mentioned in the home care brochure. So there was literally nothing, no information out there. So this was the only thing that really had been done in the way of positive, somewhat positive. Information. This was in the local paper, and then there was also a PA Now piece as well that was very similar, but that lovely picture did not appear online. Okay. So during this RPIW process, we worked with Dr. Halleck this week so that he could really tell us how best to engage those family physicians and how we could work with them to get them involved in our program and to make referrals to me. So this was the letter of introduction that is going to be circulated. Next. And there's also, we made a change to the referral form. So this is the home care referral form, and then Terry's pointing to the little box that we made at the bottom there that would indicate a referral to the COPD program or also to the home care or personal care home service that I provide. And next. And then we changed the home care brochure to include my services as in the list of all the other stuff that home care has to offer. And we developed some standard work for what is going to be done after I receive the referrals, so that it's always static and that it's always the same every time I receive a referral from any source at all. So we really wanted to increase referrals from the community so that we can stop people from going to the emergency department, and we can get their COPD well managed in their home, so that we can hopefully reduce ER visits and then reduce ER wait times and help our patients.
Hello, as many of you know, I'm Terry Fjeld. I'm one of the co-leads, and as a part of the 5S, we did a mini 5S in a cupboard in Tanya's office. Our pre-5S score was 1.18. Next, please. And our post-5S, we were able to achieve a 2.55 score. This is a pre-5S picture. You'll notice just the cabinet that we focused on was just the bottom drawer here. There was an assortment of brown paper bags with miscellaneous goodies in, so we thought we could probably do a better job of displaying them. Next, please. So what we did is we organized it, got a divider, so Tanya can just pull it out now, a quick visual to actually see what was done. We also then created a work standard, so how this cabinet is to be maintained. In the target progress report from the 5S, we were able to reduce the inventory down to an 8, which gave us a 53% reduction. And also, which was the other one? There was, inventory, were we able to, whoops, did that already. Check my notes. If I just may point out, because what we were working on is considered a new process, a designed RPIW, you'll see that we have many of the boxes where there's no measures. There was nothing for us that we could measure because this is a completely new process. Next again, please. Thank you. In our future state, you will notice that we have addressed all of the starbursts. In the current state, the whole value stream map showed the current process, and it involved the NP from beginning to end. In this process, because of the referrals coming in, now the NP starts the process right at the very end because all of the referrals are coming directly to her rather than her outsourcing them. Okay? On the event newspaper, and we did lots of digging. Up there it says problems, but we didn't think that they were problems, more like opportunities. On page 2, you'll see varying degrees of completion. We left some work, we were able to get lots done, but there's going to be a big focus after this RPIW on the communication piece. As you heard from my colleagues, this was a big secret that we know we have to continue on getting the word out there. So Tanya will work diligently visiting all the GPs, talking with all the emerge physicians to ensure the word gets out there that this great program is available. Next. So our workshop summary, we created a design RPIW. We discontinued the current process of sourcing the COPD clients and replaced with a much more streamlined process, much more efficient use of Tanya's time. Also, we created program awareness and education through the development of the home care NP brochure. We created the referral to the NP form for use by the ED physicians, and it's just one quick page and a few little tick boxes, which is what they asked us for, even though names are anonymous. We also defined the NP's role in the process to initiate her service. We engaged the family physicians through the letter of introduction, revised the home care referral form, which will be uploaded to their EMR, which is what they use currently, and created a work standard for communication and NP feedback to family physicians after a referral. This was a big missing piece that Dr. Halleck shared with us. And also we collaborated with other healthcare providers, the ACAP and PCC group, pharmacists and RTs for the enhanced program awareness and the referral process. We'd like to thank everybody who helped us out on this, and if we have omitted any names, we apologize for that. We have to thank Tanya especially. This is like a one-person program, and she was very gracious in asking the hundreds of questions that we shot at her and understanding that we were looking at not her work, but actually at the process that she was doing. So thank you again for that, Tanya. Dr. Kurtzy for being our emerge contact, Dr. Halleck for the GP portion of it, Deb Wick, Dr. Parsons, we stole him for a few moments from the other team, Brenda Brake, the ACAP staff, Alana, thank you so much for inviting us to your meeting, FitLife, Home Care, and Charity and Michelle from Health Records.